The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Welcome to Module 4, Respiratory Physiology. So let's start. Okay. So you must have heard of the term dati na respiratory tree. I really like the term because basically the respiratory system is like an inverted tree, okay? With the trachea for the trunk, the branches are your bronchi and bronchioles, and the leaves are basically your alveoli. So an inverted tree, okay? So the respiratory system can actually be divided into just two portions: the upper airways and the lower airways. Okay? Previous board exam question, they ask about the trachea. Will you find the trachea as part of the upper airway or the lower airway? So the nose, sinuses, and larynx, upper airway yon. The trachea, okay, the bronchi, bronchioles, and the alveoli, lower airways na yon. Okay? Function of your respiratory system. Okay, so if the function of the of the heart is to match the cardiac output with the venous return, the function of the respiratory system is gas exchange to allow adequate oxygen to go to the blood. Okay, allow adequate carbon dioxide to be removed from the blood. Okay, now let's discuss some of the parts of this respiratory system. First, the nose. The nose warms, humidifies, okay, and filters the air coming in, okay, into the lungs. So for smell and also for defense. Why do you need to warm and humidify the air coming in? So um, basically the nose will act as an air conditioner, no? When you say humidification, you're going to add water vapor to the air coming in. And then you need to warm the air coming in using the blood vessels in your nose. You need to do that because cold, dry air can damage the respiratory epithelium. So, kailangan mo siyang i-warm and then kailangan mo lagyan ng water vapor. That water vapor will act, okay, as a lubricant. So, in tandem with the mucus produced by the goblet cells in the respiratory epithelium, okay, the water vapor will actually act as a lubricant to prevent excoriation and damage to your respiratory epithelium. Sinuses, okay, are found in the skull. Those sinuses that function is to lighten the skull and to offer resonance to the voice. Okay? Vocal cords protect the airway from choking. Okay? Produces sounds used for speech. Okay? The trachea is found anterior to the esophagus. If this is the esophagus, the trachea is over here. Okay? Those are their cross section. And the cartilages in your tracheal rings are C-shape. They are not completely enclosed. Okay? Hindi siya O-shape. So, C-shape lang siya. Okay? Bakit siya ginawang C-shape ni God? Bakit dito sa part na to walang cartilage? The reason for this, okay, it's a mechanism basically to prevent aspiration. Dahil nandito sa likod mo yung esophagus, kapag nag-swallow ka ngayon, magbabulge forward ng konti itong esophagus whenever you swallow. Okay? This will sort of help close your trachea and help decrease the chance of having aspiration. Okay? So, it's a mechanism to prevent aspiration. Next, bronchi, bronchioles. From the trachea, you're going to have the main stem bronchi, right and left. Okay? From the main stem bronchi, it's going to subdivide several times, several generations. That's the term that we use. To lobar bronchi, segmental bronchi, terminal bronchiole, okay, etc. Okay? The magic number to remember is 23. What do I mean by that, Doc? Okay? From the trachea, okay, the subdivisions will be of 23 generations. So, magsa-subdivide yan 23 times before you reach the actual alveoli. Okay, now, yung pinaka-importante in terms of these bronchioles, bronchi, will be the terms terminal bronchioles and respiratory bronchioles. Okay? When you hear the term terminal bronchiole, the terminal bronchiole is the last part of the respiratory system without gas exchange. So from the nose all the way to your terminal bronchiole, walang gas exchange. Immediately following the terminal bronchiole, you're going to have the respiratory bronchiole. Respiratory bronchiole, meron ng gas exchange. There are only three areas in the respiratory system with gas exchange. What are those three areas? That's your respiratory bronchiole, alveolar duct, alveolar sacs. So from medial to the most lateral, respiratory bronchiole, alveolar ducts, alveolar sacs. Those are the only three areas capable of gas exchange in the respiratory system. Something that can help you in patho. You've heard of emphysema. You've heard of the types of emphysema: centroacinar, distal acinar, panacinar emphysema. Okay? Dahil ang tinatamaan palagi ng emphysema ay yung respiratory unit of the lung. So basically, yan yung respiratory bronchiole, alveolar ducts, alveolar sacs. When you hear the term centroacinar emphysema, ang tinamaan dyan is yung nasa malapit sa center. So ang centroacinar emphysema, ang tinamaan dyan will be the respiratory bronchiole. Okay? Pag narinig mo naman yung term na distal acinar, so pinakamalayo from the center, ang tinamaan dyan, ang may emphysema dyan, will be the alveolar sacs. Okay? And then pag narinig mo yung term na panacinar, pan means one. So when you hear the term panacinar emphysema, it means ang tinamaan dito will be the entire respiratory unit of the lung. Okay? The respiratory bronchiole, the alveolar ducts, and the alveolar sacs. Okay? So centroacinar, distal acinar, panacinar emphysema. Okay? Again, for your boards, relevant for you to remember, terminal bronchiole versus respiratory bronchiole. Terminal bronchiole, wala pang gas exchange. Respiratory bronchiole, may gas exchange na. Okay? So, your respiratory bronchiole, okay, your respiratory system will have what we call the respiratory epithelium. Okay? So the respiratory epithelium, its histology is important. It's a classic question in med school. First year medical students actually know this. When I ask you what is the respiratory epithelium, what will be your reply? It is ano yung histologic appearance niyan? Pseudostratified, ciliated, columnar epithelium with goblet cells. Pseudostratified, ciliated, columnar epithelium with goblet cells. Goblet cells literally would look like goblets, cups. Okay? Container for drinking. Okay? Anong laman, Doc, ng goblet cells na yan? Ang laman ng goblet cells na yan is mucus. So they will secrete mucus. That mucus will line the respiratory epithelium. Okay? And function is lubrication. Prevents excoriation of the respiratory epithelium. Okay? So, the goblet cells will produce the mucus, okay, to act as a lubricant. Hyperplasia, hypertrophy of goblet cells are seen in chronic smokers. Okay? In the respiratory epithelium, you're also going to find what we call clara cells. Okay? Clara cells are non-ciliated cells of your respiratory epithelium that will secrete protective glycosaminoglycans and metabolize airborne toxins. Clara cells were discovered by a Nazi doctor named Dr. Max Clara, who discovered Clara cells by experimenting on Jewish prisoners of war. Of course, after World War II, ang dami nila reklamo, ba't yung pinangalanan sa hayop na yan? Ang Clara cells, ay Nazi doctor yan, blah blah blah. Kaya na-discover dahil nag-experiment sa mga Jewish prisoners of war. That's why, okay, eventually Clara cells were renamed. They were renamed to club cells. However, even in textbooks, you may still see the term Clara cells. So in the med boards, Clara cells is synonymous with club cells. Then another previous board exam question. What do you call the macrophages in the alveoli? So we call them dust cells. Okay? Also called alveolar macrophages. Okay? They will remove particles, dust, okay, trapped in the alveoli. Okay? Coughing and sneezing reflex. Coughing reflex. Okay, these are the steps. You rapidly inhale 2.5 liters of air approximately. Epiglottis will then close, abdominal muscles will then relax, and then you suddenly open the epiglottis to cause coughing. Sneeze reflex is basically coughing, okay, but applied to the nasal passageways. Previous board exam question. Bold italicized in your handout. Okay, the initiating stimulus for sneezing. So probably you'll be able to get this if you see this as one of the choices. Medyo ano siya, madali naman makita. Irritation of the nasal passageways. Okay? Next, the lungs. You have two lungs, right and left lung. The right lung will have three lobes. Okay? Upper, middle, lower. The left will only have two lobes, upper and lower, because of the position of the heart. Okay? Now, hindi importante actually ang lobes. Mas importante yung tinatawag natin na bronchopulmonary segments. You have about, what, 8 to 10 bronchopulmonary segments per lung. At mas importante yung bronchopulmonary segment dahil each of those bronchopulmonary segments will have their own blood supply and their own nerve supply. We transplant according to bronchopulmonary segments and not according to lobes. Okay? Because basically, each of those bronchopulmonary segment is a small lung. Has its own blood and nerve supply. Okay? Now, very nice. Dalawa ang t-shirts ng respiratory system. An undershirt and a overshirt, a polo. Okay, over the undershirt. The undershirt is called your visceral pleura and it adheres closely to your lungs. The polo that you wear over that undershirt, over the sando, okay, that is your parietal pleura naman. So you have visceral pleura, we have parietal pleura. Okay? The parietal pleura adheres closely to your chest wall. So doon siya nakadikit sa bony thorax. Okay, parietal pleura, bony thorax, okay, chest wall. Closely adheres to that. Okay, lungs naman, okay, ang nakadikit dyan si visceral pleura. Okay? Now, between them is the intrapleural space, okay, wherein you're going to find your pleural fluid. This pleural fluid will have a negative pressure. Okay, yan ang importante dyan. May negative pressure siya. So what, Doc? Okay? Ang lungs mo ngayon at ang bony thorax mo, ang ano niyan, ang principle of how it works is this. Pag nag-contract yung diaphragm, and now the bony thorax will cause you to have ribs going upwards and outwards. Okay? Dahil may parietal pleura ka dyan na closely adhere sa bony thorax, gagalaw yun. Okay, expand. At the same time, dahil ngayon may negative pressure between the parietal pleura and visceral pleura, pag nag-expand to during inspiration, mahahatak niya itong visceral pleura na mag-expand din. So, ano mangyayari noon? Ang mangyayari noon is mag-expand na yung lungs mo mismo. Doc, hindi ko na-gets ang ibig sabihin. I call this the suction cup effect, personally. Okay? If you get yung mga parang suction cups na nilalagay halimbawa sa mga glass, sa mga windows, ba sa kotse niya, naglalagay kayo ng suction cup doon tapos may nakadikit na decoration. How does that suction cup actually stick? Okay? May negative air pressure doon sa loob, kaya yung dumitikit. So you can imagine the same thing happening between the polo and the sando, between the parietal pleura of the bony thorax and the visceral pleura of the lungs. May suction cup effect ka dito such that ngayon, during inspiration, pag yung bony thorax mo nag-expand, sasabay ngayon yung parietal pleura, visceral pleura, and then the lungs. Okay? So, gano'n ang nangyayari. So, Doc, what happens naman ngayon? Halimbawa, nasaksak yung pasyente. Okay? All the way to the pleural space between the visceral and parietal. What will happen? Well, blood and air will always flow from high pressure to low. So, in that scenario, if you create a hole from the environment going to the pleural space, we expect the pressure in the atmosphere to be higher than the pressure here between the visceral and parietal pleura. So air will enter this space, and when it enters, it will cause compression on the lungs and cause the lungs to collapse. Okay? In your handout, there's something written there na the natural tendency of the bony thorax is to expand. And the natural tendency of the lungs is to collapse. So there's a balance mediated by the pleural space Okay, such that it prevents your lungs from collapsing because every time the bony thorax will move, gagalaw din yung lungs because of the suction cup effect ng pleural space. But if you introduce air, okay, from the atmosphere and it goes to the pleural space, matatanggal na yung negative pressure, matatanggal yung suction cup effect. So the lungs now will assume its natural tendency. It's going to collapse. Okay, now, let's talk about the alveoli. Okay? The alveolar cells will come in two types. Type 1 pneumocyte, type 2 pneumocyte. Also called type 1 alveolar cells, type 2 alveolar cells. Sino ang mas madami? Common misconception. Type 1 or type 2? Sinong mas madami? No, it's not type 1. Okay? They are actually equal in number, type 1 and type 2. However, even though they are equal in number, type 1 is much larger than type 2. That's why, okay, it will make up majority of the surface area, okay, of your alveoli. Okay, but in terms of number, parehas lang talaga actually sila. So it's just that type 1 is much larger compared to type 2. Type 1 alveolar cells is the one for gas exchange. Type 2 is the one that will produce your surfactant. Okay? Ano daw ang role ng surfactant ba? Okay, you must have heard of this before. It will decrease surface tension. Ano ibig sabihin ng doc? Hindi ko gets. Kung ano yung surface tension, ek na yan. Surface tension, emit na yan. Okay? The law of Laplace states that collapsing pressure is equal to 2 times the surface tension T over the radius of the alveoli R. Okay? Surface tension is then directly proportional to collapsing pressure. Okay? Collapsing pressure, later on I'll discuss, has something to do with, discussin natin ngayon, has something to do with hydrogen bonding ng water molecules along the air-liquid interface. Bakit hindi ko na-gets? Ano ibig sabihin nun? Okay? Ito yun. Okay? Yung alveoli mo is actually lined with water. Okay? So, yung water na yan is capable of hydrogen bonding. Okay? Hydrogen bonding is a bond formed by hydrogen with either sulfur, oxygen, or nitrogen of another group. H2O, okay, has water. So, it means that H2O, okay, can form partial bonds, can form hydrogen bonds with one another. Okay, now, okay, so they will have a bond, partial bond, and they will have attraction to one another. The problem is, in an air-liquid interface, itong nandito sa taas, yung surface mo, air-liquid interface, sa surface ng water mo, itong water dito, makikipag-hydrogen bonding lang siya with kapwa air molecules, hindi siya water molecules, hindi siya makikipag hydrogen bonding with the gas. Okay? Nakipag-bond na muna siya dito sa tubig. Okay? So, ano mangyayari? Okay? Mangyayari dito is kapag nag-exhale ka at yung alveoli mo lumiit, mas malapit ngayon yung mga water molecules mo with one another. Okay? Ang mangyayari niyan is parang imagine mo 100 people nagkapit-bisig. Okay? And then ngayon na-compress kayo parehas. Ang hirap na kayong i-unbind from one another. Ganun nangyayari with the water molecules when you try to exhale now. Okay? Ang hirap mo nang i-tanggalin yan. So, ang gimmick natin dito is to add an amphipathic molecule, which is basically your surfactant. That surfactant will have a lipid and water-soluble side. Basically, ang gagawin niya is babasagin niya yung mga hydrogen bonds na yan. Okay? So, this will now decrease the surface tension. Okay? And this will now decrease your collapsing pressure. So, with the use of surfactant, must know. Okay? With the use of surfactant, surface tension will decrease. Write this down. With the use of surfactant, collapsing pressure will decrease. Write that down. And with the use of surfactant, lung compliance will increase. Okay? So, surfactant will decrease the surface tension, decrease the collapsing pressure, increase lung compliance. So, yung nagpo-produce ng surfactant, type 1 or type 2? Type 2 pneumocytes or type 2 alveolar cells. Okay? Now, when you hear the term dead space, ano ibig sabihin, Doc, ng dead space? Dead space means there is no gas exchange. It's an area with no gas exchange. So from here on, when you hear the term dead space, boom, walang gas exchange. Yun ang ibig sabihin yan. Anatomic dead space is defined as the area from the nose all the way to the terminal bronchiole. It's anatomic, it's normal, okay, it's physiologic, okay. You don't have gas exchange naman talaga from the nose all the way to the terminal bronchiole. So we call that area, anatomic dead space mo, your conducting zone because you merely conduct the air, no gas exchange is happening. Must know normal value is 150 ml. Okay? Alveolar dead space is the area in your respiratory unit of the lung, in the respiratory zone. So this is your respiratory bronchiole, alveolar duct, alveolar sac. It's the area in those three which has no gas exchange. So the normal value for this is 0 ml because normally in a healthy individual, okay, those three areas, the respiratory bronchiole, alveolar duct, alveolar sacs, should be capable of gas exchange. So the normal value is 0 ml. Okay, so alveolar dead space, okay, anatomic dead space. Those are their differences. When you combine the two, anatomic dead space plus alveolar dead space, okay, collectively we call that your physiologic dead space. Okay, so physiologic dead space is the sum of anatomic, okay, and alveolar dead space. So normally, okay, because anatomic is 150, alveolar dead space is 0. Normally, physiologic dead space is equal to anatomic dead space. Bronchopulmonary segment, we have discussed this previously, functional anatomic unit of the lung. Respiratory unit of the lung, the one capable of gas exchange. Okay, so that's your respiratory bronchiole, alveolar ducts, alveolar sacs. Okay, everything else here we've already discussed previously. So let's proceed. Okay, now, how do you compute for physiologic dead space? We're going to utilize what we call your Bohr equation. Okay, so physiologic dead space VD is equal to tidal volume VT times, okay, arterial PCO2 minus expired air PCO2 over arterial PCO2. Now, nomenclature. Okay? Dating litong-lito ako, okay, kapag nakikita ko yung capital letter A, small letter A, yung mga PaO2, PaO2, okay, PaCO2, PaCO2. Akala ko dati parehas lang. Wala, tanga eh. Medical student pa ako. Siyempre, okay, you learn. Okay, you learn as you go along. Okay? It turns out, okay, that one is alveolar, the other is arterial. So, which is which? Sino yung alveolar doc, sino yung arterial? Kapag capital letter A, siya yung alveolar. Kapag small letter A, siya yung arterial. So, alveolar PO2, okay, arterial PO2. Oxygen concentration in the arteries, oxygen concentration in the arteries, oxygen concentration in the alveoli. Partial pressure of oxygen in the arterial or alveoli. Yan yung mas proper term. PaCO2, arterial PCO2. Okay, this one, sorry, alveolar PCO2, and this one is arterial PCO2. So, nakaka-confuse talaga. So, the way to remember is that it is alphabetical. Capital letter A goes first before small letter A. Alveolar, alphabetically, will come first before arterial. So, alphabetical, yung mag-i-include ninyo para maalala kung sino yung alveolar, sino yung arterial. So, let's take a look. Importante itong formula na to. Been asked several times in the med boards. So, we gave you a poster. Ilagay nyo lang yung poster ng physio equations dun sa tapat ng study table ninyo. I would recommend, wag na kayong gumawa ng sarili nyong posters. You can, of course, I won't stop you. No one can stop you if you want to do that really. But to save time, yan ang mindset ko na is, tayo na, ang top na siya lang yung gagawa ng posters na kailangan ng estudyante. So, uniunti-unti namin yan. Starting with the October 2023 batch, we have plans for several posters. And then gradually, we'll increase it by March 2024 batch, October 2024 batch. Para makita namin. Kailangan kasi anuhin pa yan eh. Mag-undergo ng feedback, small group discussion with the students, surveys, para makita kung what works at kung ano yung gusto nila, ano yung kailangan din for the boards. So we've identified, for example, in physio, kailangan yung may poster dyan ng mga equations. For biochem, may poster dyan ng metabolic pathways na more or less kumpleto na. Okay, yung integrated pathway. Okay, so as we go along, dadagdagan pa namin yan. Okay, stand by for announcements regarding that. So the physio equations, one of them will include this one, the computation for physiologic dead space. Okay, take a look at the questions na nandyan sa physio handout niya coming from Physio BRS that will utilize this. Okay, physiologic dead space is tidal volume times arterial PCO2 minus expired air PCO2 over arterial PCO2. Minute ventilation. Okay? The amount of air that you inhale in 60 seconds or 1 minute. So the computation is tidal volume times the respiratory rate. Okay? Tidal volume is the amount of air that you inhale in the relaxed state. Approximate value is around 500 ml. We'll discuss that a little bit later. Okay? Alveolar ventilation is what we call corrected minute ventilation. Why? Compared with the formula for minute ventilation, alveolar ventilation is basically the same. However, you are subtracting physiologic dead space from tidal volume. So basically sa alveolar ventilation is kinukuha mo lang yung ano talaga yung nagamit, nag-gas exchange in 60 seconds. The amount of air na nag-undergo ng gas exchange in 60 seconds. That's why it's called your corrected minute ventilation. Okay? Let's go to lung volumes and capacities. Okay? So, we have 4 lung volumes. Okay? And we have 4 lung capacities. When you hear the term lung capacity, it is the sum of 2 or more lung volumes. We have 4 basic lung volumes, IRV, TV, ERV, and RV. Inspiratory reserve volume, tidal volume, expiratory reserve volume, residual volume. Okay? We have 4 lung capacities. Inspiratory capacity, functional residual capacity, vital capacity, the sum of the upper 3, and then total lung capacity. Okay? Classically, I tell my students, you have in you 5 liters of blood, 6 liters of air, and enough iron to create a medium-sized meal. Okay? So, 6 liters of air ang total lung capacity natin. Okay, now, let's discuss your lung volumes and capacities. It's in your handout, okay, but I prefer to draw at this stage. So, okay, silip-silipin nyo, mag-draw kayo with me. Okay, draw on the blank page of your naka-handout nyo na naka-ring bind, hopefully. Okay, and then take a look and highlight relevant portions dun sa text found in your handout. Okay, let's begin. Okay. Lung volumes and capacities. We have 4 lung volumes. The mnemonic is ITER 4321. ITER 4321. Okay. Write this down. ITER 4321. IRV, TV, ERV, RV. Okay. 3. The sum of the upper 3, IRV, TV, and ERV, is your vital capacity. 2. Okay. You have 4 lung volumes. The sum of the upper 2 is called your inspiratory capacity. The sum of the lower 2, ERV and RV, that's your functional residual capacity or FRC. Okay? And then finally, the sum of them all 4 lung volumes, is your TLC. Be able to draw this. Remember the mnemonic ITER 4321. Why? Because a classic case for first-year medical students, for those taking the PLE, for those taking the USMLE, ang classic question dyan, okay, bibigyan kayo ng certain lung volumes, certain lung capacities, and you'll be asked to compute for a particular lung volume or particular lung capacity. So, ang gimmick doon, rather than memorizing formulas, is to remember this drawing. And the mnemonic, ITER 4321. Okay? And then, madededuce mo na yan eh. Logic lang yan eh. Kapag binigyan ka ng several values dyan, so, addition, subtraction lang, madededuce mo the values of everything else. We have sample questions, okay, coming from Physio BRS in your Physio main handout. Silipin ninyo, i-apply nyo to. Okay? For now, let us describe those lung volumes and capacities and what is board relevant, okay, and clinically relevant, okay, in terms of each of them. Okay? First is tidal volume. Okay, tidal volume is the amount of air, look at your handout, is the amount of air that you inhale or exhale during quiet breathing, during the relaxed state. So during quiet breathing or in the relaxed state, you're going to inhale 500 ml, exhale 500 ml also. Inhale 500 ml, exhale 500 ml. Inhale 500, exhale 500. Okay? What is the appearance of my graph in terms of your tidal volume? Okay? It's going to look like, kasi inhale 500, exhale 500 ka lang, no? It's going to look like the tides of water. Okay? That's why they call this your tidal volume. Okay? The tidal volume, the normal value is 500 ml. Okay? Normal value of your tidal volume is 500 ml. 150 of this is found in the anatomic dead space. 350 of this is found in the respiratory unit of the lung. The respiratory bronchiole, alveolar ducts, alveolar sacs. Okay? Next is the residual volume. Okay? The residual volume, look at your handout. The residual volume is the amount of air that remains in your lungs after maximal expiration. It is a misconception that when you exhale, all the air will go out and nothing is left anymore for the lungs. No, di pwede yun. Even after maximal exhalation, there will always be air remaining in your lungs, and we call that your residual volume. Okay? That residual volume, okay, maintains oxygenation of the blood in between breaths, or whenever you're doing breath holding, whenever you're holding your breath. Okay? Remember some magic numbers. How long you can last without food, water, etc. Magic numbers. Okay? You can last for several weeks without food, only for several days without water, only for 4 minutes without oxygen, and only for a moment without love. Joke lang yung solid, guys. Okay? The magic number to remember is 4 minutes. Okay? In 4 minutes, okay, if you deny the neurons oxygen for 4 minutes, they will irreversibly die, never to live again, never to be resurrected. Okay? In those 4 minutes, the one that will maintain your oxygenation of the blood, is your residual volume. Whenever you hold your breath while you are diving, okay, underneath a pool or in the beach, it's the residual volume that will maintain oxygenation of your blood. Okay? Vital capacity. Yung mga trick questions dito, makinig. Vital capacity is the maximum amount of air that you can inhale or exhale, okay, in a given situation. So, example, if I exhale fully, and then I stop, okay, and then I try to inhale maximally, yung nai-inhale ko na yon will be my vital capacity. So, if I fully exhale to the point na ma-reach ko yung residual volume, and then I inhale fully up to my maximum capacity, that's my vital capacity. If I fully inhale now, and then I fully exhale, ang i-exhale ko will be also my vital capacity. Okay? Next, IC is just the sum of these upper two. Okay? IRV and TV. Okay? It's different from vital capacity. Okay? Ang vital capacity, okay, will include my ERV. So usually ang panlito nila sa mga questions sa mga estudyante will be vital capacity, respiratory capacity. So, halimbawa, when you're breathing normally, you stop your breathing and then you fully inhale, what you're breathing is your inspiratory capacity. But if I'm normally breathing and then I fully exhale, such that RV na lang yung meron ako, when I fully inhale now, yung may inhale ko is my vital capacity. So be careful about the subtle difference between vital capacity and inspiratory capacity. Next is FRC. FRC is ERV and RV. It's the amount of air in your lungs before the start of normal inspiration or after the end of normal expiration. So this is your tidal volume. Okay? Imagine yourself breathing right now. If you stop your breathing at the point where hindi ka pa mag-inhale, FRC yung nandyan. If you inhale, exhale, and then you suddenly stop also, Yung air na nasa lungs, okay, will be FRC. So FRC is the air in your lungs before you normally inhale or after you normally exhale. Okay? FRC. FRC has also been called your equilibrium volume. It's called your equilibrium volume because during this time, okay, atmospheric pressure is equal to alveolar pressure. No air is going in or out of the lungs during FRC because during FRC, atmospheric pressure is equal to alveolar pressure. Okay? Finally, the more relevant fact about FRC is that it is a marker for lung function. Ang marker for cardiac function is ejection fraction. Ang marker for renal or kidney function is GFR as estimated by cardiac clearance. Okay? Ang marker for lung function is FRC. If FRC is going down, you're having lung failure. Okay? So, FRC is a marker for lung function. It's also called your equilibrium volume. Okay? It's the air remaining in your lungs before the start of normal inspiration or at the end of normal expiration. When I say normal, it means relaxed state. Hindi ka nag-exercise. Okay? TLC is the total amount of air in your lungs. Okay? Approximately 6 liters. Of course, will vary once again depending on the reference that you're going to read. Okay? Other books will state 5.8, 5.9, 6.1, 6.3, 6 liters. Okay? For the physio teachers sa Pilipinas. Okay? So, next. Let's discuss FEV1 and FVC. Ano ito mga to, Doc? Okay? We use a device called a spirometer to measure expired air or exhaled air. And with that, we can compute for FEV1, FVC. FEV1 is forced expiratory volume in 1 second. Okay? FVC is forced vital capacity. So yung air na halimbawa, ang gimmick kayo sa spirometer, inhale ka ng malalim up to your maximum and then you exhale dun sa spirometer. Yung na-exhale mo after 1 second is FEV1. Yung na-exhale mo at the end, pagkatapos mong mag-fully exhale, is your FVC. Okay, now, ganito yung gimmick dyan. Okay? We use FEV1, FVC to differentiate between obstructive and restrictive lung diseases. We also use FEV1, FVC, okay, to determine severity of the condition. Okay. First, to differentiate obstructive versus restrictive. Obstructive lung disease, if you remember your basic patho, there is a problem with expiration. Hirap mag-exhale. For example, asthma patients. Hindi naman nahihirapan ng mga may asthma patients na mag-inhale eh. Okay, almost all the time, unless super severe condition nila, ang problem nila is exhalation. Okay? Restrictive lung disease, there is a problem with inspiration. Sila yung nahirapang huminga, mag-inhale. Yung obstructive, sila yung nahirapang mag-exhale. Okay? Now, in both obstructive and restrictive lung disease, take note, okay, both FEV1 and FVC individually will decrease. So, in obstructive and restrictive, both of them will decrease. May problema ka sa lungs eh. May tama yung lungs eh. Or respiratory system. Okay? However, take a look. Okay? What happens to their FEV1, FVC ratio? Yung ratio ng dalawa. Okay? Decrease ang FEV1, FVC ratio sa obstructive lung disease. While sa restrictive lung disease, it may be normal or even increase. So, ano nangyari? It has something to do with the degree of the decrease in each of those. The FEV1, FVC. Let's take a look. Kaya dalawang arrows ko dito, ang dalawa yung down arrows dito, it means nag-decrease ang FEV1, nag-decrease ang FVC, pero mas malaki, di hamak, yung pagbaba ng FEV1. Okay? Mathematically, if I have here a ratio, FEV1, FVC, if both of them will decrease, pero mas malaki ang pagbaba ng numerator ko, ng FEV1, my quotient will decrease. Okay? Now, if I have, again, a ratio between FEV1, FVC, numerator, denominator, pag parehas bumaba ang FEV1, FVC, pero mas malaki ang pagbagsak ng FVC, if I get the quotient, okay, mathematically, tataas yan. Ito ang pinaka-importante dito, okay? FEV1 FVC ratio will decrease for obstructive lung disease. FEV1 FVC ratio will increase for restrictive lung disease. Obstructive lung disease, think of COPD, emphysema, bronchitis. Think of asthma. Okay? Restrictive lung disease, think of lung fibrosis. Ang daming ways nila pwede sabihin to. Think of end-stage lung disease. Think of honeycombing of lungs. Honeycombing of lungs. Pare-parehas lang yan. May lung fibrosis. Okay? So, ano yan? Increase ng FEV1, FVC. Okay? FRC, take note, in obstructive lung disease will actually increase. While for restrictive, it's going to decrease. Ngayon, isipin nyo, Doc, kaya hindi ba maganda na yung FRC ko tumaas? Kung tumaas yung FRC ko, kaya hindi ba dapat tataas yung FVC, tataas yung one at a time, okay? FVC, okay, vital capacity is IRV, TV, ERV. FRC, okay, is RV plus ERV. So, magkaiba. So, ang nangyayari dito sa obstructive lung disease, tumataas ang FRC, tataas ang TLC, total lung capacity, pero yung vital capacity mo bumababa. Magkaiba kasi ang lung volumes ng vital capacity at FRC. Doc, tumaas ang aking FRC. Sige, sabihin mo na, okay, bumaba yung vital capacity ko, pero tumaas din ang aking TLC. Hindi po ba dapat kung tumaas ang aking FRC at TLC, hindi po ba dapat mas oxygenated yung blood ko? Hindi ako dapat mag-suffer from hypoxemia, hypoxia. No, kasi ang problema dito sa obstructive lung disease, na-damage, alimbawa, nangyari sa emphysema, na-damage yung alveolar walls such that na walang gas exchange dun sa areas na yon. May hangin sa loob ng alveoli? Yes. Okay. May oxygen sa loob ng alveoli? Yes, in emphysema. But it's not going to the blood dahil damage yung alveolar walls. So, end of the day, you'll still have hypoxemia, you'll still have hypoxia. Parang ano yan eh, parang tao, pinagtripan mo, sabi mo, oy, tol, punta ka dito sa buffet, libre ko. Then pagdating niya sa buffet, pag sabi mo, oh, sinabi ko lang pumunta ka dito sa buffet, di ko sinabing kumain ka. So at the end of the day, yung niyaya mo na tao, namatay pa rin yung sa gutom. So ganun din dito. Okay? In emphysema, in obstructive lung disease, may hangin ba sa lungs? Yes. May oxygen ba sa lungs? Yes. Increase ba yung FRC TLC? Yes. But the patient will still have hypoxemia? Also yes. Bakit siya mag-hypoxemia? Dahil hindi pumupunta yung oxygen, okay, from alveoli to blood. It just remains inside the alveoli. Parang tao na nasa buffet pero hindi makakain. Okay? So, this table is also a favorite in the exam. Okay? So, please, huwag nyo sana makalimutan. Usually, they will ask you a case. Gagawin niyang case. Case ng, magde-describe ng case ng asthma. Pwede hindi sabihin talagang asthma eh. It will just give you na may expiratory wheezing, given salbutamol, whatever. Okay? So, please be able to identify that. Okay? Need to be smart on this one. Okay? To apply this table for particular cases. That's what they are going to do. That's what I'm going to do if I'm an examiner, if I'm a teacher creating the questions for the exam. Okay? I want you to ask you point blank. Obstructive versus restrictive. What happens to FEV1 and FVC? Hindi ganun kadali. Hindi ganun ka-straightforward. We are going to utilize cases for this one. Okay? Next. Mechanics of breathing. Inhalation, expiration. So when you inhale, okay, normally, meaning not during exercise, that is an active process that will utilize the diaphragm. Normal expiration is passive, meaning no muscle is contracting. It will just occur naturally. It's a passive event. Okay? The diaphragm is innervated by the phrenic nerve. And this phrenic nerve, previous board exam question, comes from the spinal nerve roots C3, C4, C5. Okay? The cervical nerve C3, C4, C5. Okay? So it's C3, C4, C5 which will ultimately innervate your diaphragm. So implication, okay? If you cut the spinal cord anywhere from C1 all the way to C5, you're going to see a decrease in the respiratory rate. Pwedeng mamatay yung pasyente. Okay? Because C3, C4, C5, okay, innervates your diaphragm. Remember the mnemonic, C3, C4, C5 keeps the diaphragm alive. classic USMLE mnemonic. C3, C4, C5 keeps the diaphragm alive. Whenever you inhale, okay, previous board exam question, what happens? The diaphragm will contract and descend. The ribs will move upward and outward. The lungs will become wider and taller. So, nag-i-increase yung antero-postero diameter and then pati yung height nag-i-increase din. Okay? When you utilize naman the term forced inspiration, forced expiration, so this will happen during exercise. Additional muscles are going to be utilized to cause more air to come in. Forced inspiration will utilize external intercostals, these are muscles found between the ribs, and your accessory muscles, the sternocleidomastoid, SEM, anterior serrati, etc. Okay? Expiration, forced expiration, will utilize meanwhile internal intercostals and abdominal muscles. So, natanong na dati yan. So, ingat. Okay? E to I to E. Okay? Forced inspiration, I, external intercostals. Okay? Forced expiration, E, internal intercostals, I. Okay? E to I to E. Okay? And then the muscles used, additional muscles used, accessory muscles for inspiration, forced inspiration, abdominal muscles for forced expiration. Tanong na dati, sa medboards yan. So be careful. Okay? Pag guided highlighting technique tayo sa official handout nyo ha. Okay, ang i-highlight nyo lang, naka-bold, naka-italicize. I've identified them for you para hindi na kayo mahirapan. Huwag kayong trigger happy in terms of highlighting. Okay? Kung ano yung naka-bold italicized, yun yung i-highlight. Okay? Next, lung compliance. Okay? Lung compliance refers to the extensibility of the lungs. It's inversely proportional to elastance. If something is distensible, it is not elastic. If something is elastic, it is not distensible. It's not compliant. A plastic toy balloon is considered compliant. For a small change in pressure, there's a large change in the volume. Okay? A rubber band is considered elastic. You say elastic, you are able to go back to your original shape after pressure is applied to you. Okay? You don't readily change your shape. Okay? So, elastic, rubber band, compliant, distensible, plastic toy, balloon. Okay? Lungs, as previously mentioned, has a natural tendency to collapse. The chest wall or the bony thorax has a natural tendency to expand. So it's your pleural fluid which will create a balance between the two, okay? And a suction cup effect to a negative pressure in the pleural space, okay? In pneumothorax, your trachea will tend to shift away from the affected lung, while in atelectasis, the trachea will shift towards the affected lung. Okay? Surface tension, we've discussed earlier. Okay? So it's a force exerted by water molecules at air-liquid interface that tends to minimize the surface area. The basis for this is hydrogen bonding of water with one another. Okay? The law of Laplace relates collapsing pressure, surface tension, and the radius of the alveoli. Okay? In preterm babies, they are prone to having respiratory distress syndrome of newborns, of neonates. Why? Double whammy. Okay? Newborns, okay, will have high surface tension dahil ang surfactant nila is still immature. Preterm babies, okay, preterm babies will have high surface tension, okay, because their surfactant is still immature. Preterm babies will also have smaller radius ng alveoli nila because they're still developing. Talagang immature pa. So kapag mataas sobrang numerator, surface tension, mababa sobrang denominator, radius, the quotient, the collapsing pressure will be very high. What does it mean? The moment the baby will exhale, yung alveoli niya lumiit, okay, nahirap nang ma-inflate again dahil mataas yung collapsing pressure. Okay? So some key points about surfactant, etc. Cells that will produce surfactant is type 2. Main component of surfactant is water. Active component of surfactant is DPPC, okay, dipalmethyl phosphatidylcholine, also called lecithin. Okay? That's why, ano yung pang-testing natin sa mature surfactant? Amniotic, not plasma levels, ha? Amniotic, lecithin, sphingomyelin ratio. Dahil lecithin is DPPC. So, an amniotic LS ratio of more than 2 is to 1, okay, will herald maturity of your surfactant. This is what we want, okay? DPPC is amphipathic, has a lipid-soluble and water-soluble side, okay? Your surfactant will increase the lung compliance but decrease surface tension and collapsing pressure. Start of surfactant production, controversial. Some books will say 24, others 25, others 26 or 28. Okay, let's choose 24. Maturation of surfactant, also controversial. Some references will say 32, 33, 35, 36. Let's choose 35th week AOG. Treatment for a newborn with a respiratory distress syndrome. Okay. Surfactant kung hindi pa steroids kung hindi pa pinapanganak. Surfactant kung pinanganak na. So the steroids will hasten the maturity of your surfactant. So kung hindi pa born yung baby, use that. Kung pinanganak na, use synthetic surfactant. What steroids do we utilize for patients, for newborns with a respiratory distress syndrome? Okay, a previous board exam question. Do we use cortisone, hydrocortisone, dexamethasone, betamethasone? So the answer to that, we're going to use dexamethasone or betamethasone. Okay, what is dexamethasone, betamethasone? Are they short-acting steroids, intermediate-acting steroids, or long-acting steroids? So dexamethasone and betamethasone are long-acting steroids. Mnemonic. Okay? Dexamethalone, betamethalone. Contrast that with cortisone, hydrocortisone. Cortisone and hydrocortisone are short-acting. Prednisone is intermediate. So, cortisone, hydrocortisone, betamethalone, dexamethalone, okay? Prednisone will be somewhere in the middle, okay? The law of Pasui can also be applicable to airway resistance. Okay, so viscosity of gas is N, length of the airway, radius of the airway, that's L and R, okay, listed here. The three factors affecting airway resistance will include bronchial smooth muscles, okay, lung volumes, and the viscosity, okay, of gas. Okay, now, in the alveolar blood gas exchange, we have two terms here, perfusion-limited gas exchange and diffusion-limited gas exchange. Perfusion-limited gas exchange is the transport of oxygen, okay, in the alveoli, okay, at rest during normal conditions. So right now, probably you're at rest or not exercising, so you have what we call perfusion-limited gas exchange in your alveolar pulmonary capillary, okay? Diffusion-limited gas exchange involves the transport of oxygen during exercise. Okay? So, ano ibig sabihin ng mga terms na to, Doc? Okay. Perfusion-limited gas exchange. So, we have here your alveoli, and we have here your pulmonary capillary. Oxygen is supposed to move from the alveoli to the pulmonary capillary. At rest, okay, the gas exchange is perfusion limited, or another way of saying this is blood flow limited. They might use that term in the med boards, blood flow limited. At anong ibig sabihin nito, Doc? Okay? Readily, sumasakay yung oxygen mo nakakapunta sa pulmonary capillary. Yung carbon dioxide nakakapunta doon sa alveoli without any problem. Ang limiting factor mo is the blood flow. Okay? Take a look. This is the length of your pulmonary capillary. And this is arterial oxygenation. Okay? In the first few parts pa lang, very early in the length of the pulmonary capillary, mataas na ang saturation. Taas na yung oxygenation. Okay? So it means, okay, itong oxygen na to, sumasakay kaagad sa pulmonary capillary. Ang naglilimit ngayon of how much oxygen that you can get from the lungs is blood flow. You are perfusion limited. Okay, ang transport ng oxygen mo during resting conditions, under normal conditions. Parang halimbawa, ang application yan. Okay? Oxygen para mga pasahero. Halimbawa, mga estudyante yan. Tapos yung pulmonary capillary, parang mga jeep. So at rest, okay, may 10 passengers, may 10 pasahero, may isang jeep. Okay? Gawin natin 100 na pasahero, may isang jeep lang. So readily, sasakay yan ng jeep. So, ang naglilimit ng pag-transport mo sa 100 na pasahero will be the number of jeeps. You are blood flow limited. Okay? What happens during exercise? During exercise, nag-i-increase ng blood flow sa lungs. Okay? So, ano mangyayari? Okay? Nag-increase yung blood flow sa lungs. Ngayon, ang naglilimit na ng pag-gas exchange mo is the gas itself. Yung ability niya, okay, na makapag exchange na makapunta halimbawa dito sa pulmonary capillary. Nag-increase na kasi yung blood supply mo during exercise. You are now diffusion limited or what we call gas limited. You're limited by the inherent characteristic of the gas. Analogy. Okay? Dito, during exercise, parang meron ka ng 1,000 na jeepneys. Pero dito, meron ka pa rin 100 na pasahero. Okay? Pero yung pasahero mo, lahat yan maarte. So, ayaw nilang sumakay talaga ng jeep. Gusto nila sumakay ng Alphard, sumakay ng magagandang kotse. So, dahil maarte sila, uy, jeepney, yak. So, hindi ka agad sila sasakay. So, ngayon, hindi ka na blood flow limited. You are now, okay, diffusion limited. The inherent characteristics of the gas is the one that limits gas exchange. Okay? So, perfusion limited gas exchange. Okay? On boards, you see this in the transport of gases at rest. Okay? Diffusion limited gas exchange, you will see this during the transport of gases during exercise and during diseased states. Okay? Oxygen is transported in the blood two ways. Okay? 98% is transported via hemoglobin. 2% is transported completely dissolved in plasma. Okay? So, hemoglobin will have four chains na may iron, and those iron, the ferrous form, to be more specific, can bind with oxygen. Okay? So, the normal values for your hemoglobin, previous board exam questions, is 13.5 to 17.5 grams per deciliter, lower in females. Okay? Lower in females. Now, kapag ang hemoglobin mo, take note, it can bind with oxygen, or it can bind with carbon dioxide, or it can bind with carbon monoxide. Pag oxygen ang nakadikit, ang tawag natin dyan, oxyhemoglobin. Pag carbon dioxide ang nakadikit, ang tawag natin dyan, carbaminohemoglobin. At pag carbon monoxide ang nakadikit sa hemoglobin, ang tawag natin doon ay carboxyhemoglobin. Okay? So, be careful. Okay? Carbon monoxide poisoning. Anong ginagawa daw pag may carbon monoxide poisoning? You get carbon monoxide poisoning from classic na case na nasa kotse, Doc, palpak yung aircon, carbon monoxide poisoning. Unless your car is from the 1980s, that rarely happens nowadays. Usually, you get carbon monoxide poisoning from burning buildings. Okay? When you burn wood, material, carbon monoxide is released. Okay, the problem with carbon monoxide, okay, because the air is 80% nitrogen, about 19% oxygen, 1% other gases. So kahit may carbon monoxide sa environment, usually the amount of oxygen will still exceed the amount of carbon monoxide. Okay, however, okay, ganito kasi yung gimmick dyan. Pag may isang carbon monoxide na dumikit sa hemoglobin, kahit yung other sites magbabind ng oxygen, ang nangyayari dito is the carbon monoxide, okay, will cause what we call a shift to the left of the O2 hemoglobin dissociation curve, which basically means itong oxygen na to, okay, will remain bound to hemoglobin. Hindi sila mag-unload. Okay? So, what will happen in carbon monoxide poisoning? Will your blood be highly oxygenated? Yes. Okay? However, will you die of hypoxemia, hypoxia? Also yes. Will you die of hypoxia? Yes. Why will you die of hypoxia in carbon monoxide poisoning? Because the oxygen is not unloading to the tissues. It's not unloading to the muscles, not unloading to the neurons. So at the end of the day, you're still going to die. Okay? Patients with carbon monoxide poisoning will have a cherry red appearance. Classic pathologic description. Cherry red appearance. Their cherry red appearance is explained by the fact, okay, na yung blood nila is highly oxygenated. But they die of lack of oxygen dahil hindi pumunta sa tissues. Nag-remain lang sa blood. Mamamatay kang tisay with carbon monoxide poisoning. Cherry red appearance. Okay? Now, take note that oxygen will bind to the ferrous form of iron and not to the ferric form of iron. Okay? The ferric form of iron is what we call methemoglobinemia. Okay? Treatment for methemoglobinemia is methylene blue. Mnemonic, met, hooray! Met, hooray! Methylene blue for methemoglobinemia. Adult hemoglobin is alpha 2, beta 2. Okay? Fetal hemoglobin is alpha 2, gamma 2. I'll explain later, okay, bakit dinesign ni God na iba yung fetal hemoglobin. Okay? Actually, nandito na pala. Explain natin ngayon pa lang, Doc. Okay. Your 2,3-BPG comes from 1,3-biphosphoglycerate. 1,3-biphosphoglycerate is an intermediate of glycolysis. Inside the red blood cell, that 1,3-BPG is converted by an enzyme called BPG mutase into 2,3-BPG. So you will only see your 2,3-BPG inside the RBCs. Okay, that 2,3-BPG binds more with adult hemoglobin. Okay, so what, Doc, if it will bind more with adult hemoglobin? The fetus cannot breathe on its own. It gets its oxygen from maternal blood. So you need to have a mechanism to transfer oxygen from maternal blood to fetal blood. From maternal hemoglobin to fetal hemoglobin. So ang gimmick noon is having 2,3-biphosphoglycerate and having different types of hemoglobin for adults and for babies. 2,3-BPG binds more with adult hemoglobin. Okay, this 2,3-BPG will cause a shift to the right of the O2 hemoglobin dissociation curve. Ano ibig sabihin nun? It will cause unloading of oxygen from the hemoglobin. So, pag nag-unload yan sa placenta, kanino pupunta yan? Boom! Kay fetal hemoglobin. So, God designed the hemoglobin of adults to be different from the fetus. Okay? To ensure transfer of oxygen from maternal blood to fetal blood. From maternal hemoglobin to fetal hemoglobin. Okay? Oxygen binding capacity, a previous board exam question, is 1.34 ml. Okay, let's talk about the O2 hemoglobin dissociation curve. So the O2 hemoglobin dissociation curve, classically, it's been described as having a sigmoidal shape. Hindi siya linear. Okay, the reason for that is a positive cooperativity. Ano ibig sabihin noon? Okay? So, sige, tirahin natin to. Let's draw. Okay? So the O2 hemoglobin dissociation curve is sigmoidal in shape and has been described as having positive cooperativity. Ano ibig sabihin ng positive cooperativity na yon? Your hemoglobin can bind with 4 units of oxygen. Ang gimmick ganito. Pag ang isang oxygen molecule nakadikit kay hemoglobin, mas mabilis makadikit ng pangalawa. Pag dalawa nakadikit, mas mabilis makadikit ngayon ng pangatlo. At pag tatlo nakadikit, pinakamabilis makapag-bind ng pang-apat. The opposite is also true. Pag nag-unbind yung oxygen, isa nag-unbind, mas mabilis makapag-unbind ng pangalawa. Pag dalawang na-release, mabilis makarelease ng pangatlo. Pag tatlo napakawalan, pinakamabilis makarelease ng pang-apat. Ano ibig sabihin nito? Okay? Your red blood cell has limited time in the lungs, limited time in the tissues like muscles or neurons. So, ang gusto mo kay hemoglobin is mabilis siya makapick up ng oxygen pag nasa lung siya, mabilis siya mamigay ng oxygen pag nasa tissue siya. So, pag nasa lung siya, gusto mo mabilis ang pag-pick up niya ng oxygen. Pag nasa tissue siya, gusto mo mabilis ang pag-release niya ng oxygen. That's why it's given that positive cooperativity. Okay? In biochem, you're going to discuss yung taut forms and the lax forms ng hemoglobin. Basically, yun yung basis kung bakit ang bilis niya makapick up ng pangalawa, pangatlo, pang-apat. Okay? Ang bilis din niya mag-release. Okay? The more na napapakawalan niya yung oxygen. Okay? Yung taut and the lax form niyan. Okay? Now, okay? This is the reason why you see, okay, a sigmoidal curve when it comes to your O2 hemoglobin dissociation curve and not linear. Okay? The sigmoidal curve, okay, is a graphical representation of that positive cooperativity. Okay? Kaya hindi linear. Meaning kapag Nakadikit ng isa, mabilis makadikit ng pangalawa. Dalawa nakadikit, mabilis makadikit ng pangatlo, pinakamabilis makadikit ng pang-apat. Opposite is also true. Pag nag-unbind yung isa, mas mabilis makapag-unbind yung pangalawa, pangatlo, pinakamabilis yung pang-apat. The sigmoidal curve reflects is a graphical representation of that positive cooperativity. Okay? So let's draw an O2 hemoglobin dissociation curve. How will we draw that, Doc? Okay. X-axis, y-axis. Divide into 4 equal parts. Okay? The x-axis is your arterial PO2. Okay? 25 millimeters mercury, 50, 75 millimeters mercury, 100 millimeters mercury. Okay? The y-axis, okay, is hemoglobin saturation. Hemoglobin percentage saturation. So you have here, divide it also into 4 parts. Okay? You have here 25% saturated, 50% saturated, 75, 100. Okay? There is a value that we call P50. The P50 is the arterial PO2 wherein you have 50% hemoglobin saturation. Okay? The normal P50 is 25 millimeters mercury. So, ibig sabihin nito, at 25 millimeters mercury, so this is my P50 and 25 millimeters mercury. At 25 millimeters mercury, I am 50% saturated. So, with that in mind, if you draw a line intersecting here, 50%, 25 millimeters mercury, you now draw a sigmoidal curve that will pass through that point, and you will now form a perfect O2 hemoglobin dissociation curve. Okay? Now, ano ang ibig sabihin ng shift to the right and shift to the left? When you say shift to the right, literally, okay, yung O2 hemoglobin dissociation curve mo, pupunta rito. May right shift ng curve. Okay? This will happen if you have an increase in your kabit. An increase in your kabit will cause a shift to the right. An increase in your carbon dioxide, acidosis, 2,3-biphosphoglycerate, exercise, and temperature. An increase of any of these 5 will cause a shift to the right. Okay? A shift to the right means there is increase unloading of oxygen from hemoglobin. Okay? Now, let us take a look. What is common to all of these 5? What is common to hypercarbia, acidosis, increased 2,3-BPG, exercise, and temperature? Common to all of these 5 is hypoxia. The tissues will experience hypoxia. Hypercarbia associated with hypoxia. Pag may acidosis ka, may hypoxia. Pag may 2,3-BPG ka, halimbawa, classic case niyan, high altitude or respiratory disease, like COPD. Pag meron ka niyan, meron kang hypoxia. Exercise and temperature, pag nag-increase yung demand, okay, meron kang hypoxia. So all of this will cause a shift to the right, which implies an increased unloading of oxygen from hemoglobin. Now, do you want that? Do you want a shift to the right ng O2 hemoglobin dissociation curve mo whenever you're experiencing hypoxia? Okay, the answer is yes. Why? Okay? Dahil when your tissues are starving for oxygen, like your skeletal muscles and neurons, gusto mo, pag may dumaang hemoglobin na may oxygen, gusto mo ibigay niya agad yung oxygen dahil you're already hypoxic. Okay? Parang analogy dyan, ganito. Parang halimbawa, ikaw, gutom na gutom ka na. Nag-order ka sa Pizza Hut, 9111111. Gusto mo, yung delivery guy, okay, yung rider, pag binigay yung pizza, ibigay niya kaagad. Hindi na yung, Doc, before I give you the pizza, I know you're hungry, but before I give you the pizza, I'd like to sing you a song. Ayaw mo, gago ka ba? Gutom na ako, bigay mo na yung pizza. Gusto mo ganun siya. That's why, okay, you have a shift to the right. That shift to the right will increase increase the unloading of oxygen from hemoglobin, which is useful in a hypoxic tissue. Okay? So an increase in your kabit will cause a shift to the right. Mnemonic. Okay? Go to the PowerPoint. Kabit, do the right thing, let go. An increase in your kabit will cause a shift to the right, and shift to the right means letting go of oxygen. Okay? Now, what will cause a shift to the left? A shift to the left, okay, will involve a decrease in your kabit. A shift to the left will also involve an increase in your carbon monoxide or fetal hemoglobin. So an increase in your carbon monoxide or fetal hemoglobin will cause a shift to the left. Okay? So Doc, itong O2 hemoglobin dissociation curve, please take note, it's a favorite in the med boards. Okay? Itong pandemic batches ng Board of Medicine since 2020, paborito ang O2 hemoglobin dissociation curve. March 2023, October 2022, ang daming tanong about the O2 hemoglobin dissociation curve. If not in physio, they can ask this in biochem, they can ask this in patho. So some key things to remember, lilituin kayo, okay? They will ask you about shift to the right ba? Shift to the left ang nangyayari. They'll give you cases. So let's do a quick review. Okay, you tell me whether there's a shift to the right or left. What if there is a decrease in carbon dioxide, right or left? So that is left. Okay, an increase in carbon dioxide, right or left? Right. An increase in carbon monoxide, left. Okay. An increase in plasma pH. An increase in plasma pH will make the blood more alkaline, so shift to the left. A decrease in plasma pH. Okay, so that is acidosis, so that is shift to the right. Okay. High altitude, shift to the right, increase 2-3 BPG. COPD, shift to the right. Okay, increase 2-3 BPG. Exercise, shift to the right. Fever, shift to the right. Okay, they may give you ABG values. Okay, as long as you know how to interpret the acidosis or alkalosis. Acidosis is shift to the right. Alkalosis shift to the left. Burning buildings. Okay, carbon monoxide poisoning, shift to the left. Fetal hemoglobin, shift to the left. Okay? I hope tama yung mga nabanggit ko. Okay? So, tama yan. Basta tandaan nyo yung natin, kabit, do the right thing, let go. Yung mga nasa, pag nag-increase yung carbon, ang panglito palagi dyan, yung favorite namin, even for first year medical students, the favorite there is yung carbon dioxide at carbon monoxide. That's one. Okay? Yan yung panglito. Pag tumaas ang carbon monoxide, shift to the left. Pag tumaas ang carbon dioxide, shift to the right. Isa pang panglito dyan is acidosis. Okay? Increase acidity ng blood, acidosis, shift to the right. However, remember, ang plasma pH bumababa. So, decrease in plasma pH, okay, will increase acidity, so shift to the right. So, itong plasma pH, panglito yan ha. Pag nag-increase yung plasma pH, shift to the left. Pag nag-decrease yung plasma pH, shift to the right. Okay? So, be careful. Kabit, do the right thing, let go. Okay? So, 98% of hemoglobin, of oxygen is transported via hemoglobin, 2% transported, freely dissolved in plasma. For carbon dioxide, okay, how do we transport? 70% is transported as chemically converted into bicarbonate. 23% of the carbon dioxide is bound to hemoglobin, and 7% is freely dissolved in plasma. Okay? Hypoxemia versus hypoxia. Hypoxemia is not synonymous with hypoxia. When you say hypoxemia, mababa ang arterial PO2. Pag sinabi mong hypoxia, mababa ang tissue PO2. Okay? Can hypoxemia lead to hypoxia? Yes. But are all cases of hypoxia caused by hypoxemia? No. Hypoxemia leads to hypoxia, but not all cases of hypoxia comes from hypoxemia. Okay? So hypoxemia, the AA gradient is used to differentiate between causes of hypoxemia. Hypoxia, if you have it, okay, it will trigger EPO production, the increasing red blood cell production. So your AA gradient is A minus A, alveolar PO2 minus arterial PO2. Okay? In theory, the normal value of your AA gradient should be 0. Why? Okay? Kasi dapat yung oxygen from the alveoli should go to the pulmonary capillaries until mag-equilibrate sila, until maging equal yung partial pressure dito sa alveolar at sa arterial. Okay? So, kapag minus mo dapat yan, it's a number minus the same number, dapat 0 ang difference nila. Kasi equal yung number eh. Okay? Yun yung ideal. However, in reality, the normal AA gradient is actually 10 millimeters mercury. A positive number, positive 10 millimeters mercury. It means the alveolar PO2 is always higher than arterial PO2 by about 10 millimeters mercury. And the reason for that, okay, is because hindi lahat ng lungs may blood supply. So, ibig sabihin nito, may areas ka na may shunting. So, it means may mas mataas palagi ang alveolar PO2 compared sa arterial PO2 because may area sa lungs na hindi napapatakan, okay, yung blood ng oxygen. Hindi nabibigyan. Okay? Now, causes of hypoxemia. Ang more relevant dito is knowing kung sino yung may increased AA gradient. You will see an increased AA gradient kapag mas mataas di hamak yung alveolar PO2 compared sa arterial PO2. So you will see this, okay, pag hindi mo ma-transfer properly yung oxygen from alveoli to the blood. So if there's a problem in transferring oxygen from alveoli to the blood, mag-i-increase ang iyong AA gradient. So what are these? Diffusion defects, ventilation perfusion defects, right to left shunts. High altitude hypoventilation, walang problema sa pag-transfer ng oxygen from alveoli to the blood. Ang problema dyan is, sa high altitude, manipis lang talaga yung hangin, konti yung oxygen na makukuha mo from the environment. Sa hypoventilation, mabagal yung paghinga mo. Pero yung may problema ba? Is there anything stopping the transfer of oxygen from alveoli to blood? Wala. Kaya normal ang AA gradient nila. Okay, relevant for the med boards. Cause of hypoxia, okay, one of them can be hypoxemia, but there are other causes listed here. Anemia, carbon monoxide poisoning, cyanide poisoning, decreased cardiac output can all cause hypoxia. So carbon dioxide, again, transported three ways, chemically converted to bicarbonate, okay, bound to hemoglobin, called carbaminohemoglobin, or freely dissolved in plasma. How about nitrogen, Doc? How is it transported in the blood? Nitrogen is unique because it's not chemically converted into anything in the blood. It's also not bound to hemoglobin. 100% of your nitrogen will be dissolved in the blood. And in the board exams, yung nitrogen na yan is relevant only in the context of Caisson disease of decompression sickness, which we'll discuss in your last module. Okay? So, in terms of your pulmonary circulation, when you compare it with the systemic circulation, the pressure is less than systemic, resistance is also less than systemic, but cardiac output is equal. Remember, cardiac output of the left heart is equal to the right heart. Okay, now, pulmonary blood flow, okay, in a standing position, at rest, standing, okay, blood flow in a standing position is highest at the base, the lower one-third, highest perfusion. Okay. The apex, the upper one-third, will have the lowest, okay, pulmonary blood flow. So because of gravity, gravitation effects, because of the arrangement of blood vessels in your lungs, okay, pulmonary blood flow, standing at rest, lowest at the apex, highest at the base. However, in a supine position, lying down, supine, okay, mag-i-equalize yan throughout the lungs. Okay? Effect of hypoxia on pulmonary arterioles. Hypoxia, when it comes to systemic arterioles, it will cause them to vasodilate. Okay? But hypoxia, in terms of pulmonary arterioles, it will cause them to vasoconstrict. Why will they vasoconstrict? In the pulmonary arterioles, the response to hypoxia is vasoconstriction in order to shunt the blood towards better ventilated areas of the lungs. The lungs does not have uniform ventilation. Some areas are better ventilated than others. Since the blood in the pulmonary arteriole, the goal is to pick up oxygen, hindi siya pupunta sa lugar na wala masyadong oxygen. So magva-vasoconstrict yung pulmonary arterioles to shunt blood towards better ventilated areas, those that carry more oxygen. Okay? So, other lung vasoactive substances, thromboxane A2, prostaglandin A2, causes bronchoconstriction. We have your leukotrienes. Specifically, board relevant, your leukotriene C4, D4, and E4 are collectively called, okay, your SRSA. Slow, reactive, substance of anaphylaxis. This SRSA is the one that will trigger asthma. Okay? The steroids that we give to patients will target this SRSA and decrease the incidence of asthma. Okay? Haldane and Bohr effect. Ano yung Haldane and Bohr? Okay? Haldane effect, as the mnemonic implies, occurs in the lungs, L to L. Bohr effect, okay, mnemonic B to B, occurs in the body tissues. So ano yun, Doc? Okay? Remember, 23% of your carbon dioxide is transported via hemoglobin. So we have here what we call, okay, your carbaminohemoglobin. So may carbon dioxide na nakadikit. Ang gimmick ngayon sa carbon dioxide mo, kapag pumunta ang carbaminohemoglobin dito sa lungs, what will happen? Okay, pagdating sa lungs, yung carbaminohemoglobin mo, ang mangyayari is mag-unload yung carbon dioxide from hemoglobin, tapos didikit ang oxygen. Okay? So oxygen in the alveoli will cause carbaminohemoglobin to release its carbon dioxide, tapos didikit yung hemoglobin mo. So you'll now form here in the lungs your oxyhemoglobin. That oxyhemoglobin will eventually find itself in the body tissues like muscles or neurons. So in the body tissues, meron kang production ng carbon dioxide from the Krebs cycle. Ang gimmick mo ngayon, yung carbon dioxide na yan will cause a shift to the right of the O2 hemoglobin dissociation curve. So i-unload niya yung oxygen. The oxygen now will go to the tissues. Tapos sa hemoglobin na to, ang didikit is si carbon dioxide. Okay, so you now form carbaminohemoglobin. That carbaminohemoglobin will go to the lungs, form oxyhemoglobin. That oxyhemoglobin will go to the body tissues, forming carbaminohemoglobin. So it's a cycle, if you've noticed. The Haldane effect and the Bohr effect. Okay? Now, a common misconception when it comes to reading Physio-BRS. I already gave you instructions. Don't read Physio-BRS anymore. Everything that's important there is already incorporated in your Physio handout, main handout ng top notch, supplemented by Guyton, by Byrne, by previous feedback from students. So, kompleto na. Okay, save time, no Physio-BRS. Nothing anymore, okay, except the main handout, okay? There are still questions na hindi natin mako-cover, but those are crossover, trivial questions, or nooks and crannies. But what you really need to know to become good physicians, we will cover. Okay? One of the things na problematic sa Physio-BRS is the lung zones. If you read Physio-BRS, you're going to have this misconception na yung apex of the lung is zone 1, yung middle part is zone 2, yung base part is zone 3. No, it's not. The lung zones there is not an actual zone or an actual area. It's a scenario. Okay? Ano yung scenario doon? Ano yung ibig sabihin? Okay? Your alveoli has a bunch of grapes appearance. Interspersed within them are your pulmonary capillaries. So, basically, your pulmonary capillary is surrounded 360 degrees by this alveoli. If you want blood flow to happen in that pulmonary capillary pressure must be greater than pulmonary alveolar pressure. If pulmonary alveolar pressure is greater, it will compress on that pulmonary capillary and prevent blood flow. These lung zones are scenarios. They should have named them Scenario 1, Scenario 2, Scenario 3 para hindi nalilito yung estudyante. What are these scenarios? Zone 1 is a scenario wherein there's no blood flow to that particular pulmonary capillary. In this, the pulmonary alveolar pressure, okay, is greater than pulmonary capillary pressure, whether systole or diastole. So the alveoli will compress on the pulmonary capillary, no blood flow. Zone 2, there is intermittent blood flow. Okay? During systole, pulmonary alveolar pressure is less than pulmonary capillary pressure. But during diastole, pulmonary alveolar pressure is greater than pulmonary capillary pressure. So during systole, there is blood flow. During diastole, no blood flow. Okay? So intermittent yung blood flow dyan. Zone 3 is continuous blood flow. In this scenario, pulmonary alveolar pressure is always less than pulmonary capillary pressure. Okay? So continuous ang blood flow dyan. So again, no blood flow. Alveolar pressure is greater than pulmonary capillary pressure. Okay? All the time. In zone 2, intermittent, it's less than pulmonary capillary pressure during systole, greater than pulmonary capillary pressure during diastole. And in zone 3, okay, pulmonary capillary pressure is higher than alveolar pressure all the time. No blood flow, intermittent blood flow, continuous blood flow. Zone 1, Zone 2, Zone 3. Okay? The way to remember this, parang electric fan. Di ba yung mga electric fans natin, may button 1, button 1, 2, and 3. At yung pinakamalakas is yung 3. So, yung continuous ang 3, yung no blood flow ang 1. What do we actually see in the lumps? Okay? Apex versus base in a standing position, resting position. Apex, you're going to see zone 2 and zone 3, intermittent and continuous. Zone 3 for middle and base. So this is standing position. Okay? In a supine position, it becomes zone 3 all throughout. During exercise, it becomes zone 3 all throughout. So, Doc, normally walang zone 1. Wala, kasi zone 1 is no blood flow. Hindi takasigad na mag-engineer siya na ang laki-laking portion ng lungs walang blood supply. Okay? So, zone 1, you're only going to see that whenever there is respiratory diseases. Pulmonary hemorrhage, positive pressure ventilation, you're going to see zone 1. Otherwise, hindi dapat siya nakikita in a healthy individual. Next, let's discuss ventilation-perfusion ratio. V is ventilation, hangin. Q is perfusion, blood flow. I didn't use letter P because usually P in physics stands for pressure. Okay? So if we divide the lungs into apex, middle, and base, and then compare, what can we learn from this? Look at this diagram, okay? Ventilation alone is highest in the base. Perfusion alone is highest in the base. Because of gravitational effects, the way we arrange our yung anatomic arrangement ng blood supply, lung tissues, okay, blood flow, and ventilation, standing position, okay, at rest, okay, highest at the base. Okay? However, the ventilation-perfusion ratio, which is more important, is highest in the apex. Ventilation alone is not important. Perfusion alone is not important. What's important is their relationship, the VQ ratio. Dahil pag mataas ang VQ ratio, ang implication niyan is mataas o maganda ang gas exchange. Ibig sabihin niyan, pag mataas ang VQ ratio mo, okay, yung oxygen mas nakakapunta sa pulmonary capillary from the alveoli. Yung carbon dioxide mas natatanggal from the pulmonary capillary, mas pupunta siya sa alveoli. Maganda, mabilis, malakas ang gas exchange pag mataas ang VQ ratio. That's why ang TB, ang reactivation niyan is doon sa apex. Kasi ang TB, nagre-require ng oxygen. Okay? So dahil maganda yung ventilation-perfusion ratio mo, it means efficient. For a given amount of blood, mas nalalagyan siya ng oxygen. So napaka-efficient. So yan ang preference ng TB mo. Yung mataas na VQ ratio na yan. At dahil mataas yung VQ ratio mo sa apex compared sa base, take a look. Previous board exam question. Your arterial PO2 is highest sa apex. Dahil mas nakakapunta yung oxygen papunta sa pulmonary capillary. Mayaman tuloy sa oxygen yung pulmonary capillary. Arterial PCO2 is lowest in the apex. Why? Yung CO2 mas natatanggal from the pulmonary capillary. Mas nakakabalik siya sa alveoli. So, nagde-decrease to. Okay, remember, for the apex, okay, lowest ventilation, lowest perfusion, apex, but highest ventilation-perfusion ratio. When you have a high ventilation-perfusion ratio in the apex, it means maganda ang gas exchange. Ergo, okay, mataas ang arterial PO2, mababa ang arterial PCO2. Highlight everything here, this part, okay? Yan yung pang-boards dyan. Be able to understand and explain this to an 11-year-old. You will know you understood something if you can explain it to an 11-year-old, a grade 5 student. If you can explain it to an 11-year-old, okay, you really understood it. Okay? So, when you are learning physiology, try to do that exercise. Try to explain it to a friend, to a layman, to an 11-year-old. Okay? You will simplify, of course, what you're explaining, and you will have a good grasp of what you're saying. Okay? Of what you're studying. Okay? Components for the control of breathing will involve the following. For example, the cerebral cortex can override the autonomic brainstem centers. Breathing is normally an involuntary process. Okay, it's supposed to be automatic. However, the cerebral cortex can override. You can consciously control your breathing if you want to. Okay? Now, the medulla and the pons. The medulla will be the one to create the basic respiratory rhythm. This is where you're going to find the dorsal and ventral respiratory group. The dorsal respiratory group is the main respiratory center that triggers inspiration. The DRG will basically send, okay, a signal to your diaphragm for it to contract. Okay? It will cause what we call the, ganda ng name, no? Inspiratory ramp signal. It ramps up the diaphragm to cause it to contract. Okay? That's the job of the DRG. So parang sinasabi niya kay diaphragm, mag-contract na tayo tol, mag-contract na tayo tol, contract na tayo tol, inhale, inhale, inhale. Okay, exhale. Contract na tayo tol, contract na tayo tol, inhale, 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 exhale. The exhalation is a passive process. So that's the job of your DRG. It's the main respiratory center. Okay? Your VRG will supplement the DRG during exercise. So VRG is for forced inspiration and forced expiration during exercise. Your pneumotoxic and apneusic centers are found in the pons, and they modify the basic respiratory rhythm of your DRG. So anong gagawin ng pneumotoxic apneusic center? Kung halimbawa, ito yung inspiratory ramp signal, okay, tapos ito yung duration ng breathing mo, inhalation, exhalation. Your pneumotoxic center in the pons will shorten the duration of inspiration. So if you shorten the duration of inspiration, inhale, 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 exhale. Inhale, 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 exhale. So you will have more cycles per minute. Tumataas yung frequency. So the pneumotoxic center at the end of the day will, okay, increase your respiratory rate. Okay, pneumotoxic center. Okay, parang may pneumonia. Di ba sa pneumonia, yun yung talagang hindi pwedeng cutingin yung pag-measure mo sa respiratory rate. Kailangan talaga pinapabilang sa yan, especially sa community. So, pneumotoxic center will increase your respiratory rate. Apneustic center, found in the pons, will do the opposite. It will prolong the duration of inspiration. Okay, so if this is normal, inhale, exhale. Okay, ito, patatagalin niya. Inhale, 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 exhale. Inhale, inhale. The duration will be longer, with apneustic center stimulating the DRG. Less cycles are formed per minute, and you will see a decrease in your respiratory rate with your apneustic center. Okay? So, Doc, pang boards. Okay, pang boards. Main respiratory center, DRG. Supplements the DRG during exercise, VRG. Okay? Increases the respiratory rate, pneumotoxic center. Decreases the respiratory rate, apneustic center. Para ka may apnea. Central and peripheral chemoreceptors. Central chemoreceptors are found in the ventral medulla. They respond directly to CSFH+. The CSFH+, this one, that stimulates the central chemoreceptors. The CSFH+, ultimately comes from plasma CO2. Okay? Can plasma CO2 directly stimulate the central chemoreceptors? No. Can plasma H plus directly stimulate the central chemoreceptors? No, also. It cannot pass through the blood-brain barrier. The one that can directly stimulate the central chemoreceptors is CSFH plus. Okay, when stimulated, it will cause an increase in your respiratory rate. Peripheral chemoreceptors are located at two sites, the carotid and aortic bodies. Okay, differentiate them from carotid sinus aortic arch, where you're going to find the baroreceptors. Peripheral chemoreceptors are found in the carotid and aortic bodies. Okay, these peripheral chemoreceptors respond to three things. Hypoxemia, which is low arterial PO2. Hypercarbia, which is high arterial PCO2. And finally, acidosis, which is high plasma H+. Among the three, the most potent trigger for peripheral chemoreceptors, previous board exam question, is hypoxemia. Okay? It mainly responds to hypoxemia. Arterial PO2 of less than 60 millimeters mercury to be more specific. When stimulated, it will increase your respiratory rate. So the other two, okay, can trigger your peripheral chemoreceptors, but it's mainly hypoxemia which will trigger your peripheral chemoreceptors. So mnemonic, central chemoreceptors is triggered by CSFH+, peripheral chemoreceptors, pang low oxygen. It is triggered by hypoxemia. Okay? Stimulated by lung distension, prevents overinflation of the lungs, prevents rupture of the lungs from overinflation. Those are your lung stretch receptors. The reflex to prevent overinflation of the lungs, we call that your Hering-Brewer reflex. Stimulated by lip movement and causes an anticipatory increase in the respiratory rate during exercise. Joint and muscle receptors. So kapag nag-move ka ng katawan, hindi na hinihintay ng katawan na maging hypoxic ka. The moment you start moving, joint and muscle receptors will trigger an increase in your respiratory rate. Irritant receptors are triggered by noxious chemicals in the environment, triggers bronchoconstriction. J receptors were named J because they are found in juxtacapillary areas and they are responsible for the feelings of dyspnea. Okay? A previous board exam question. Remember, the mnemonic. Okay? Sinong responsive? Anong ginagawa ng J receptors? Siya ang nagkukos ng feeling ng dyspnea. Dyspnea. Pronounce it that way para malaman mo na J receptors yun. Then finally, okay, these are the respiratory responses to exercise. Okay, increase oxygen consumption, CO2 production, increase RR, increase venous PCO2, increase pulmonary blood flow. So, nag-i-increase ang metabolism, nag-i-increase ang paghinga, nag-i-increase ang gamit ng oxygen, okay, during exercise. Normally, arterial PCO2 should not change. You should not experience hypoxemia. You should not experience hypercarbia. You should not experience acidosis or alkalosis even when you are exercising. Normally. Okay? However, if you have strenuous exercise, severe exercise, that will now cause lactic acidosis, causing a decrease in your arterial pH. Lactic acidosis ka. High altitude. The problem with going to a place of high altitude, okay, is that at high altitude, there is low, okay, oxygen, partial pressure of oxygen in the atmosphere. Ergo, mababa ngayon ang alveolar PO2 mo, bababa din ngayon ang arterial PO2 mo. So, bababa ang arterial PO2, bababa ang alveolar PO2. So, what will happen? As compensation to the high altitude, you will see an increase in the respiratory rate. Okay? The arterial pH will increase because of the increase in alveolar, in your arterial pH will increase dahil sa pagtaas ng respiratory rate, bumaba ang arterial PCO2. Nung bumaba yung arterial PCO2 mo, it was blown off to the environment. Okay? Bumaba ngayon ang carbonic acid sa blood mo. Nung bumaba yung carbonic acid, naging alkaline siya, tumaas ang arterial pH. Okay? Hemoglobin concentration, 2,3 BPG, will increase as a response. Okay, you want an increase in your red blood cell. Okay, and you will also have pulmonary vascular resistance. It will increase because of the constriction ng pulmonary arterioles in response to hypoxia in the lungs. Okay, so these are the respiratory responses to exercise and high altitude. So that's it for respiratory system. Okay, so hopefully ito na yung last na marinig niyong respiratory physiology lecture. Okay, just a few weeks. Okay, pag doktor na kayo, every learning na lang is just for fun. Yun yung pinakamasaya eh. Pag nag-aaral ka na lang just for fun, in preparation for residency, in preparation for foreign exams, or in preparation for general practice. Okay, thank you so much.